Hey there, health enthusiasts. Welcome back to our channel. Today we've got the topic intussusception. Please subscribe and ring the notification bell to stay updated on all the latest videos. Without waiting, let's dive into the topic. Intussusception is the invagination of a segment of the intestine into the adjoining intestinal lumen. The invaginating portion of the intestine, called the intussusceptum, completely telescopes into the receiving portion of the intestine, called the intussuscipiens. The commonest site is a segment of the ileum moving into the colon, through the ileocecal valve. This process leads to bowel obstruction, venous congestion, and bowel wall ischemia. Perforation can occur and lead to peritonitis and shock. May occur at any age, but most commonly between 2 months and 2 years of age. If left untreated, however, this condition is uniformly fatal in 2 to 5 days. There are 2 variants when assessing the cause. Idiopathic intussusception, which usually starts at the ileocolic junction and affects infants and toddlers. Most cases are idiopathic, around 90%. Enteroenteric intussusception, jejunal, jejunoileal, ilioileal, which occurs mostly in older children where a pathological lead point may be the cause. Lead points can be Meckel's diverticulum, Haynock-Schönlein purpura, lymphoma, luminal polyps, e.g. Peutz-Jeghers syndrome, hemangioma, Kaposi sarcoma, cystic fibrosis. Other causes: electrolyte derangements, recent bowel surgery, rotavirus vaccination. The classic triad of intermittent abdominal pain, palpable abdominal mass, and red currant jelly stools, which is a late sign suggesting bowel ischemia and infarction, occurs in only 1/3 of children. Pain is colicky, severe, and intermittent. The child draws the legs up to the abdomen and kicks the legs in the air. In between attacks, the child appears calm and relieved. Episodes can recur within minutes to hours and may increase in frequency over the next 12 to 24 hours. Diarrhea. Lethargy may be the only presenting symptom. It may be profound, episodic, or persistent. Initially, vomiting is non-bilious and reflexive, but when the intestinal obstruction occurs, vomiting becomes bilious. Right hypochondrium sausage-shaped mass and emptiness in the right lower quadrant, dance sign. Crossing the midline in the epigastrium or behind the umbilicus, best palpated between spasms of colic, when the infant is quiet. Abdominal distension frequently is found if obstruction is complete. The child is pale, diaphoretic, and hypotensive if shock has occurred. Tenderness or guarding may suggest perforation and peritonitis. Inspection of the nappy and perianal region should be done. A rectal examination is rarely indicated. Fever and leukocytosis are late signs and can indicate transmural gangrene and infarction. Always resuscitate and stabilize the patient before starting investigations. Ultrasound scan is the most commonly used one. It has high sensitivity and specificity. But it is highly operator dependent. It should not be used to exclude the diagnosis. Shows target and pseudo-kidney signs. Abdominal X-ray. Performed if there are signs of obstruction or perforation. A normal X-ray does not exclude intussusception. Signs suggesting intussusception on an abdominal X-ray include absence of air in the right lower and upper quadrants and a right upper quadrant soft tissue density. A soft tissue mass surrounded by a crescent licency of bowel gas, crescent sign. Lack of fecal material in the large bowel. Small bowel obstruction, dilatation and air fluid levels. Pneumoperitoneum indicating bowel perforation. Enema. Contrast or gas enema can be used. The enema may be used diagnostically and therapeutically. There is a small risk of bowel perforation and bacteremia during the gas enema. Therefore, the enema is performed where pediatric surgery is available in case of the need for laparotomy. Contraindicated if peritonitis, shock, perforation, or an unstable clinical condition is present. Blood tests such as blood glucose, venous gas, FBE, and UEC if the child looks unwell. Blood group and hold before the theater. When managing the child, involve a pediatric surgeon as early as possible. If the child presents with hypovolemia or shock, need to address it first. Start intravenous fluid resuscitation and nasogastric decompression as soon as possible for all. In non-operative reduction, therapeutic enemas can be hydrostatic, with either barium or water-soluble contrast, saline or pneumatic, with air insufflation under fluoroscopic or ultrasonographic guidance. It is successful if initiated early. There is no value in patients with small bowel intussusception. The recurrence rate of intussusception after non-operative reduction is less than 10%. More than one recurrence suggests the presence of a lead point. If can tolerate diet discharge 12 to 18 hours. Surgical reduction. If the non-operative reduction is unsuccessful or if obvious perforation is present. Traditionally with a right paraumbilical incision, the intussusception is delivered into the wound, and gentle manual pressure is applied to pull the intussusceptum out of the intussuscipiens. If the manual reduction is not possible or perforation is present, can do a segmental resection with an end-to-end anastomosis. Nowadays, laparoscopy is used. Associated with faster recovery times, decreased length of stay, decreased time to full feeds, and lower requirements of pain medication. The flow chart shown is from RCH Guidelines. As stated in RCH Guidelines, analgesia and resuscitation should precede the investigation. Secure for access for all children suspected to have intussusception before diagnostic imaging. Involve the surgical team early and keep nil orally. Treat hypovolemic shock with 4 boluses of 20 ml per kilogram normal saline. Give adequate analgesia, usually intranasal fentanyl or 4-morphine. Pass nasogastric tube if bowel obstruction or perforation on X-ray, or if planning transfer by air. Children with intussusception can decompensate while undergoing ultrasound and/or air enema. Ensure medical or nursing escorts are capable of providing resuscitation if needed. We conclude today's discussion on intussusception. If you found this video helpful, please consider sharing it with others who may benefit from the knowledge. Thank you for joining us today, and we look forward to bringing you more informative content in the future. Until next time, take care and stay well.